Welcome to day two. We are live now with this first session in Hall B, Grunzig Hall. Here we have a case of cardiogenic shock, and it's my pleasure here to invite you all. The results of yesterday's quiz. Remember, we have quizzes that are happening. Last session we had 89 attempts, and we'll be declaring the winners at the end of the session today. And we have another quiz based on again the same. All the formats and the questions that we have based on all the debates and the sessions that are scheduled today. So I encourage all the fellows to go ahead and start attempting that. So can we have the slides, please? So the first bout is on cardiogenic shock. So for the session, I invite Dr. Abhimanyu Kothari, Dr. Kilol Kaneria, Dr. Harsh Gonia as moderator, Dr. Raj Rawal, Dr. Gaurav Singh, and Dr. Jigisha Sachde as chairperson. Over to chairperson to do the honors of introducing our elite speakers. Gaurav, you need to unmute. Yeah, please.
Our first speaker will be Dr. Bhupesh Shah. He's a DM cardiologist. He's a senior interventional cardiologist at SCG Hospital and associate professor at SVC Hospital. He has completed his fellowship in cardiac science from Charles Nicolas Duran and France, and is a gold medalist in pharmacology also. Our second speaker would be from USA, Dr. Aditya. He is a cardiologist and associated professor at Loma Linda University Medical Center. He inserted impeller device and a stent through axillary artery instead of a femoral artery in the groin in a challenging case. He has a special interest in cardiovascular diseases and intervention cardiologist. Our third speaker would be our own Dr. Chirag Doshi. He is a CVTS senior surgeon at UN Mehta Institute of Cardiology in Ahmedabad. He is also HOD of at CVTS at UN Mehta. So we are dealing with a case of hyperacute MI, a young male with a history of fever since 2 days. With a tachycardia, with hypotension on a low dose inotrop, and he's also having fever since 2 days and a saturation of 94%. He also had an episode of VT which is successfully DC-verted. His RT-PCR is awaited, and on echo he has a moderate MR, and ABG is showing acidosis with lactate of 4. So what would be the preferred mechanical assist device for primary PCI in this patient? Can we have the ECG? This is a 12-lead ECG showing a hyperacute MI with ST elevation in anterior leads. So our preferred mechanical assist devices, whether it be Ampula, ECMO, or IVP. So I would like to invite this is angio showing osteoproximal LAD occlusion. So we can see the complex anatomy, osteal involvement, and again there is a lesion in mid LAD also. So what are the things to learn here? Acute anterior wall MI in COVID times, whether we will go for the same strategy or anything new is there. Device assisted primary PCI in cardiogenic shock. What is the current status of IVP over the new assist devices? And what is the mortality benefit versus cost benefit of Ampula? So I would like to invite our first speaker, Dr. Bhupesh Shah, to initiate his talk. Sir, please.
Yeah, just share the screen. Good evening, friends and seniors, and congratulations, Dr. Kamal. And this is already being described, the history of the patient, but one or two important things which I like to mention here. That is, one is the history of fever here. Even in the patient is having the corona era, but still with the proper precaution, we can take this patient in the Cath lab. Another thing was low dose noradrenaline patient was requiring. Third important thing, there was the ischemic mitral regurgitation, that is the 30 to 35%. So most important thing, when the patient present with cardiogenic shock, ideally we should have the shock team. And the most important thing is the types and the trends of the complication of the institution we need to know, because that is very, very important. Let us just go through very quickly the various stages. That is A, B, C, D, E. The A at the risk, B is the beginning, and the C is the classic. So here we can say that this patient is having the anterior MI, that is, patient is having a cardiogenic shock. I think we can put him here somewhere around class C. And there was one history that was DC shock was given, so we can have one modifier A here. So in these circumstances, we know that in all of we cardiologists, we are very much tuned with the IABP. Our staff is very much well versed with the IABP, and we do not have any shock team in certain institutions. So I think in our setup, and also in this case, when the patient is having the class C approximately and having the one modifier A, I think IBP we can think of, and we can proceed for the intervention, because we know in cardiogenic shock, intervention which have shown that it reduces the mortality in the patient. That is the first thing. And what is about class C here, lactate which is more than 2, that is low dose of the noradrenaline or supports which are being required. And we need to have more markers. What is the renal function in the patient? What is the urine output of this patient? What is the cardiac index? What is the right atrial pressure, pulmonary waste, etc. So this is shock team, which is a combination of the cardiologist, cardiac surgeon, intensivist, and then we have to take the decision in this particular case. So I think in this particular case, as the patient is having the ischemic mitral regurgitation, I think still IBP, which is very important choice in this case, because ischemic mitral regurgitation is there. Patient is having the blood pressure around 80, 89, and this is, we need to differentiate between the decompensated heart failure versus acute cardiogenic shock. Here in another multiple predictors which are included in the ACS, MCS mortality risk score. This is very tricky, because in this age which is more than 60, which is given 1 point, lactate more than 2.5, 1 point, kidney injury 1 point, and the stage E 1 point. So if we go for the ACS, MCS, here the patient is young, so only lactate. So here we can say there is only 1 point which comes as far as the mortality risk score is concerned, or point, only 1 score is there. We can see the predictor mortality and the observed mortality in the range of 20 to 25%, which is there. And if we have the shock team, of course, this is the very important criteria. We need to know whether the patient is having the right-sided heart failure or not, because right-sided dysfunction, which usually gives the high mortality in this patient. But as the patient is having acute myocardial infarction with mitral regurgitation, I think instantly we should put the patient on the IBP. Why IBP was out, we know that ESC guidelines, which have considered that routine use of the IBP in the patient with cardiogenic shock is class 3. But we can see here that those patients who are having the mechanical complication, like the ischemic mitral regurgitation, ventricular septal defect, still IBP is very, very important in this particular condition. When the patient is having acute myocardial infarction, we need to establish the LAD circulation as early as possible. This is how IABP, which was according to the European guideline, it was class 3, but still look at the American College of Cardiology classification, it is again the class 2B, and level of evidence, it is C. Why it is like that? Because in the majority, if you can look at this ESC guideline, many these were based on the expert opinions. So I think we, in our particularly setup, particularly in Indian countries, when the patient is having the acute myocardial infarction, patient is on the low dose noradrenaline, though lactate level was a little high, I think intra-aortic pump should be implanted. And first of all, we should open up this LAD territory, because there is revascularization is the only thing which has improved the mortality in the patient. And IBP shock 2 trial, we know that mortality was lower than expected. Ejection fraction was little high in that case, but 86% of the cases, we can see majority of the cases, this IBP implantation, which was done after the intervention was over. This is very, very important. Of course, there were certain data that pre-intervention and after intervention, but majority of the patients, IBP was implanted later on. But this is a subgroup analysis. When the age is less than 50, if the patient is having no history of previous myocardial infarction, there is no history of hypertension, some positive signals were still found in this trial, as a result of which this is the young patient, no prior history of myocardial infarction, and our purpose is to revascularize LAD as early as possible. I think IBP is still effective and it works because these are the certain studies which are there when the IBP was implanted before angioplasty, IBP after angioplasty. So if IBP was implanted before PCI, we can see that is definitely, it is the positive signal and the p-value was quite significant in this case. And this is the various, I think in subsequent lectures, we are going to know more about Impella and this ECMO devices. We know that IBP is very important, and later on, we can also upgrade to the further Impella or ECMO as and when required, when the patient is having the history of, I mean, we are doubtful about the history of fever. And we do not know what is the status of COVID in this patient. But still, when there is some myocardium, it is preserved. IBP, I think, still works. And we know the journey of Impella because in the previous trial, Impella usage in acute myocardial infarction with the shock, which has increased significantly. And later on, it has shown the positive, the PROTECT 2, PROTECT 3, now PROTECT 4 trial, which is going on. And the most important thing is that prevalence of the acute limb ischemia, because if we are going for the higher version of the mechanical support, the most important thing is the large bore devices which are required. And we have to know, most important thing, selection of the patient, right device in the right time, which is important, and explantation of the device is also very important. So if there is acute limb ischemia and if it is left untreated, almost 100% mortality would be there in the hospital. So when we are going for the large bore devices, very, very aggressively, we have to observe this patient. So this is the various shock trial. We can see IBP implantation. I think this is very important, and that is difference between the acute myocardial infarction and cardiogenic shock and the acute heart failure, because in the acute myocardial infarction, cardiogenic shock, hypotension, hypoperfusion, and ultimately they have congestion, while in case of acute heart failure, they are congested first, then hypoperfusion, and then hypotension will take place. The most important of our duty is that these are the cardiogenic shock loop. We have to prevent the patient going deep into the stage E. So this is how, if the patient is not improving, then we can escalate the mechanical cardiology support. And this is the catheterization intervention, this last month journal. We can see that what they are saying, that this is very important. We do not have still major trial. We do not have much data. And still this MCS, mechanical cardiology support, these devices, they are very expensive. Invasive intervention with inherent industry, physician, and the health system financial interest that may increase the utilization, we know. So a lot of trials which are required to have this Impella and the ECMO. We know that when the patient is having the D and extreme stage, this Impella and this ECMO devices, this is very important device. But still, in this particular given case, I think IBP, we have to implant this patient, and as early as possible, we should open up. Then we have to observe this patient, and if urine output falls and cardiac index which goes down, we can escalate. So before escalating the therapy, I think IBP is very important, because whatever this observation was, the majority of the cardiologists, I think 50 to 60% cardiologists, instantly they will put IBP. So management of the cardiogenic shock is quite complex. Sky shock classification is a simple way to describe the patient, and only proven therapy to improve the survival in acute MI shock, that is the revascularization. So by all means, we have to revascularize the patient first. Significant knowledge gap about data supporting the various percutaneous MCS device, and every device has the profile of risk and the benefit. And managing the sick patient, it is very critical to match the need with the tools which are available. So I think this is very important. We can say that IBP still works in many patients, and particularly those who are having the mitral regurgitation, ventricular septal defect, when we want to have very, very rapid, because our staff is also well versed, particularly in our Indian setup. So this is very substantial amount of the IBP use is there in our country. Need to be little bit more aggressive in terms of replacing the cardiac function. ECMO and Impella, they are also alternative. So this is, I think, in absence of the clear guidelines and the decision regarding the escalation, which are largely guided by the goal of normalizing the hemodynamics. I think drugs which are being given, our goal is to have the less amount of this vascular support to the patient, because they are again very dangerous. First, we need to put on the IBP, Then see what is the urine output of the patient, what is the cardiac index of the patient, whether the patient is in hypoperfusion, multi-organ defect or not. And then we can escalate therapy to the impella and tandem. And if there is right ventricular dysfunction, then additional right ventricular support, which is required. So this is, I think, our escalation, which is done in the acute myocardial infarction with the cardiogenic shock. So in this given patient having ischemic myocardial infarction, acute infarction, ischemic mitral regurgitation is there. And our Indian setup, I think impella, IBP, which is available in every setup, while impella is not available. So I think this is the IBP, which is still effective and is going to work in this case. Thank you very much for your kind attention.
Thank you, Bhupesh Bhai. It was an excellent talk. Now you explained your part really very well. Now I would like to introduce Dr. Aditya Bhardwaj from USA. Sir will explain about the role of impella in such type of the scenario.
Thank you. Thank you very much. And thanks for having me. This is really a great conference. Congratulations to Dr. Kamal Sharma and his team. And so today I'm going to argue for using impella as the best strategy in this case, or I would say at least as a first line strategy. So we've heard about the clinical scenario. We've looked at the EKG and the angiogram. So just to summarize, basically this is a young patient with COVID and acute MI cardiogenic shock. And like we talked about, he's somewhere between stage C to D. I would argue that he's actually stage D because he's failed the first line, which is usually vasopressors and inotropes. He's failed that, and now he's requiring mechanical circulatory support. So he's deteriorating. He also has ischemic mitral regurgitation. It's moderate. His lactate is 9. I think that's a very important thing to remember, that this is a really sick patient. A lactate of 9. All studies have shown that lactate is a significant predictor of mortality in these kind of patients. So I think it's very clear that we have a very sick patient who really needs help. So I'm going to first talk about, a brief comparison between the different types of mechanical circulatory support, give a brief overview of the different catheters within the impella family, the hemodynamic benefits of impella, best practices for use of impella, and then finally the use of impella for LV unloading, even if we chose to put in an ECMO in this patient. So the types of percutaneous mechanical circulatory support, this is something that I think we're all pretty familiar with. We have the balloon pump, we have impella, tandem heart, and VA ECMO. I'm not going to go into great details of all these because I think it's pretty clear, but I think the mechanism by which these different devices act is really important. So like we know, balloon pump acts by the mechanism of counterpulsation. Impella is a MCS that directly unloads the LV. It takes the blood out of the left ventricle and ejects it into the aorta. Tandem heart, like we know, is basically an LA to AO conduit. And VA ECMO, like we know, it basically draws blood from the venous side, oxygenates it, and pumps it back into the arterial system. And we're all pretty familiar with the sheath sizes. So definitely balloon pump has the lowest sheath size. Impella is somewhere in between 13 to 14 French, and ECMO definitely uses much larger bore axis. But I think the thing to remember about impella is that it decreases afterload. Like we're going to talk about, that's a very important factor, and how it's very different from VA ECMO, which on the other hand increases afterload. Impella increases mean arterial pressure, it increases cardiac flow, cardiac power, it decreases LVEDP and LV preload. It increases coronary perfusion, and it decreases myocardial oxygen demand. I'm going to talk about each of these in a little bit as we go along, because that's a very important thing to remember if we're going to say that this patient should get impella first. Before I go to that, a brief overview of the different devices in the impella family. I think impella CP and 2.5 are the most commonly used left-sided devices. CP gives you a forward output of around 3.5 to 4 liters per minute. 2.5, which we almost never use in cardiogenic shock, only used in high-risk PCI, and really not even used much these days. gives about a 2.5 liters of additional cardiac output. Impella RT is a right-sided device. It's used for right-sided shock, and it's put in percutaneously through the femoral vein. Then Impella 5.0, LD, and 5.5 are all surgically inserted pumps, usually used by the cardiac surgeons. And these require arterial cut down, or Impella LD is by way of direct surgical insertion. Now, all these three pumps are comparable to ECMO in terms of the forward cardiac output they provide. So it's usually 5 liters or above that these devices provide. But again, like I said, they're surgically implanted. So hemodynamic benefits of Impella. So why do I say that this young patient should get Impella as the first-line mechanical circulatory support? It's because of all these hemodynamic benefits that the Impella provides. So first and foremost, like we know, it increases flow across the aortic valve. So it increases the cardiac output, and it increases end organ perfusion. It increases mean arterial pressure, also accomplishing these two things. But by far, the most important benefit of Impella is that it directly unloads the left ventricle. It decreases LV end diastolic pressure and LV end diastolic volume. And this is a very, very important feature which no other mechanical circulatory support device provides. So what are the benefits of decreasing the LV end diastolic pressure and the volume? It decreases wall tension, which in turn decreases microvascular resistance, which in turn has two really beneficial effects. It increases the myocardial perfusion and increases the myocardial oxygen supply. And as a result of decreasing the left atrial pressure and decreasing the pulmonary congestion, there is decrease in oxygen demand. So this is a patient who's had a large myocardial infarction, and he's in heart failure and cardiogenic shock. So one of the most beneficial things that you can do is increase the oxygen supply to the myocardium and decrease the oxygen demand by the myocardium. That itself is going to help the native heart recover, and you can actually prevent this patient from ending up with a lot of scar and potentially prevent situations of going into an LVAD or a transplant. Now, in addition to that, Impella, by decreasing LV end diastolic pressure and volume, decreases the mechanical work, and we'll talk about that a little bit. And there's hypothesis generating studies from animal models suggesting that there's cardioprotective signaling and preventing reperfusion injury. Now, there's all this stuff that I just said is all backed by data. Data comes from the CVAD registry, which is a global multi-center registry comprising of Impella patients. So, there are a large number of patients in this registry, and here you can see there is different hemodynamic parameters that Impella improves the mean arterial pressure, cardiac output, cardiac power output, which I'm going to talk about in a little bit, and it decreases the pulmonary capillary wedge pressure. Cardiac power output, this is a very important hemodynamic index to remember when we're treating patients with cardiogenic shock. It's mean arterial pressure into cardiac output divided by 451. And more to come on that in just a little bit. Now, comparing Impella to balloon pump, there was the ISAR shock trial, which is a randomized controlled trial. It was a really small trial, but nevertheless, it looked at Impella 2.5 versus balloon pump in treating patients with cardiogenic shock. And just from this trial alone, we see that Impella, and this was 2.5, it was not even the CP, significantly improves the cardiac output. So you have the native cardiac index, which actually goes down. So the patient's native heart is resting while the Impella actually takes over the function of the heart. And balloon pump, like we know, very modestly increases cardiac output, maybe by about 500 ml per minute, if at all. And this is actually a really cool slide, which I like to show in my presentations. So this is basically a side stream dark field imaging that is used to look at sublingual microcirculation. This was done in an animal model. This was a patient, an animal patient who was in cardiogenic shock. And this is with the Impella device turned off versus Impella device turned on. So like we talked about how Impella improves cardiac output, it improves end organ perfusion. So like you can see here, there's significant improvement in the sublingual microcirculation 48 hours after being on Impella support as compared to the baseline. So I think this is also a really important slide. So I think we're all aware of the hemodynamic support that different types of interventions provide, whether it's inotropes, balloon pump, ECMO, or the Impella family of devices, they all increase the cardiac power output by different amounts, which we just talked about. Now, what about myocardial protection, or PVA? And I'm going to talk about that here. So when you talk about myocardial protection, let me tell you, inotropes, balloon pumps, and ECMO actually have a negative effect on myocardial protection. So it's almost counterintuitive, and it's ironic that ECMO increases afterload, and so do inotropes and vasopressors, which increase the afterload, are putting further stress on an already failing heart in a patient with cardiogenic shock. So Impella is the only device which actually protects your myocardium and helps with native heart recovery. So going back to pressure volume loop, I think we need to go back to the basics to understand why Impella is beneficial. So we're all pretty familiar with the pressure volume loop. So you have the left ventricular pressure on the y-axis and left ventricular volume on the x-axis. And this, as we know, represents the cardiac cycle. And so what exactly do we mean by myocardial protection, and how does Impella do it? So there's something called the pressure volume area, which is a measure of the total mechanical energy that correlates with myocardial oxygen consumption. So it's made up of two things. There is the stroke work, which is the area under the pressure volume loop, which is a measure of mechanical energy. And there is the potential energy, which is a measure of the stored energy. And the sum of these two is called the pressure volume area, which is the stroke work plus potential energy. And this is the entire area under this pressure volume graph. And so I would actually refer those of you who are really interested in basic physiology to read this paper by Dr. Braunwald, published in 1999 in JACC, which extensively talks about this concept. So like I said, pressure volume area, it's a measure of total mechanical energy that correlates with myocardial oxygen consumption. So what Impella does is, so this red line that you see here, the red pressure volume loop you see here, is after a patient has been started on Impella, as compared to this blue pressure volume loop, which is at baseline. So putting a patient on Impella actually shrinks their pressure volume loop by decreasing their left ventricular end diastolic pressure and volume. So what that does is it reduces the PVA, because it reduces the volume under this pressure volume loop, as a result of which it reduces the mechanical and potential energy, therefore reduces the myocardial oxygen demand. Now, in addition to that, I told you that Impella also increases myocardial oxygen supply. And the way it does that is by decreasing the wall tension. And for that, we need to go back to the law of Laplace, which states that the wall tension is proportional to the maximum pressure by volume. So like I said, Impella reduces left ventricular end diastolic volume and pressure, reduces the wall tension, reduces microvascular resistance, as a result of which it increases myocardial oxygen supply. And this is, again, a very important concept to remember, how Impella actually improves the coronary flow. And it does that by increasing the aortic pressure and by decreasing microvascular resistance. Both of these factors are an important driving force for coronary blood flow. And this is, again, a really cool picture. So this is actually the planar images from a gamma camera in a patient who had 3-vessel disease, who had CTO of his circumflex and RCA, which was untreated. And the LAD had a severe stenosis, which they opened up with Impella on and off. Like you can see here, in the absence of Impella, despite opening up the epicardial artery, there's a significant perfusion defect, as opposed to a protected situation where you have the Impella on, you open up the epicardial artery, and there's actually good myocardial flow in this area, because all the capillary blood flow is recruited by way of unloading by the Impella. Now, I've talked a lot about pathophysiology and hemodynamics. So you may say, show me the data, show me the clinical data and best practices for Impella use in cardiogenic shock. How many minutes do I have here?
Dr. Aditya, your time is up. Can you just sum it up in 1 or 2 minutes?
Okay, sounds good. We'll do that. Okay. So really quick, I'm going to quickly go through this algorithm of National Cardiogenic Shock Initiative, which you all know was a multi-center trial that was done in the US, and we at Loma Linda were actually part of it. We were one of the highest enrollers. So the basic concept of the National Cardiogenic Shock Initiative is early identification of cardiogenic shock, pre-PCI use of Impella. So I think that's a very important thing to remember. So it's not just important to open up the culprit artery, but it's important to unload the LV before you do it. And the use of right heart cath, which Dr. Bhupesh Shah also talked about, important to look at these indices, look at the cardiac power output, look at the pulmonary artery pulsatility index, and decide which is the right kind of support device to use. And why was NCSI so important? Because we achieved 77% survival in NCSI. This is significantly better than all the previous shock trials like the IABP shock trial, culprit shock trial, and so on, which had survival only in the 40s to 50%. And this was the publication that we published. And before I finish, one last word. I think next we're going to hear about use of ECMO in this situation, which is definitely not unreasonable. But the only thing I would add is that even with an ECMO in place, most centers in the world are today using Impella to unload the left ventricle, even with an ECMO in place. And I think data for that comes from this really nice circulation paper in December 2020, which basically showed that they looked at consecutive patients. All of them got ECMO. About half of them had an Impella in addition to unload the left ventricle. And patients who had unloading with Impella in addition to ECMO had a much reduced mortality at 30 days, despite a higher risk of vascular complications. So I think, like we all agree, there is definitely a trade-off. But despite that trade-off, I think patients, when you unload them with Impella, they do better. So like I said here, Impella has all these different hemodynamic benefits. It helped, but the most important thing is that it helps with native heart recovery by decreasing oxygen demand and increasing supply. And when we're using Impella, it's really important to remember the best practices: early identification of shock, pre-PCI use of Impella, and use of right heart cath to guide decisions for escalation and de-escalation. And finally, I think even if we're considering ECMO, there should always be an Impella to unload the LV. Thank you.
Thank you, Dr. Aditya Bhardwaj. It was excellent talk. You very well explained about the Impella. Of course, it's cost effective. We'll discuss later on. Now, I would like to invite Dr. Chirag Doshi. Actually, it's a pre-recorded talk of Dr. Chirag Doshi on ECMO, role of ECMO in such type of scenario. So we can start the recording of the Dr. Chirag Doshi.
Good morning, everyone. First of all, I would like to thank Dr. Kamal Sharma and the organizing committee of CardioCon 2022 for having me here. I'm an esteemed company and I'm honored for being invited. I think Dr. Bhupesh and Dr. Anand have elegantly put forth their points, but still I would like to suggest that ECMO would be the ideal choice for these 34-year-old patients, and let me try to convince you as well. So let's review the case scenario. A 34-year-old man, hyper-acute MI with a 2-day history of fever, which I think cannot be ignored. As we all know, during these COVID times, we have seen so many sudden cardiac deaths in young individuals, and a lot of them had coronary thrombosis. So this young male is tachycardic, hypotensive, on noradrenaline support, and his saturations have already started falling. So he had to be intubated. He had primary ventricular tachycardia and has been cardioverted with an ejection fraction of 25%, with moderate mitral regurgitation and hypokinetic elevated territory. But the most alarming thing in this scenario, which stands out, are his lactates are 9 mg/%. And this is very important to consider in the decision-making process. So we all know the sequence of events that follows a myocardial infarction. So this chart shows the sequence of events that eventually lead to progressive myocardial dysfunction and eventually morts and death. There have been several trials that have evaluated this problem. The IABP Shock 2 trial, which was a randomized controlled trial comparing IABP and OMT, which showed no mortality benefits at 30 days, 6 months and 1 year. Then came the IMPRESS trial comparing IABP and Impella. There was again no mortality benefits at 30 days. Then the most significant thing which occurred in the field of cardiogenic shock was the Detroit Cardiogenic Shock Initiative, and with their protocolized approach to the problem, they managed to improve the survival rate for cardiogenic shock post-MI to 76% from 50% for the first time to 2 decades. And this was a real eye-opener for all of us. So early and effective device support is critical for survival. So as we can see, both the numbers of vasopressors and lactate levels correlate directly with mortality. Our patient already has in-hospital mortality approaching 60% as denoted by this red line. Also, stepwise escalations of support, delays treatment, and almost 65% of cardiogenic shock patients receive Impella or ECMO only after failing IBP. So we have to intervene before the hemodynamic problem becomes a hemometabolic problem. And for this, the reason we have to provide adequate circulatory support to provide systemic perfusion, adequate ventricular support by LV or RV unloading, optimum coronary blood perfusion, adequate hepatic and renal unloading, and this will for the basis of our discussion regarding MCS device choice. Also, the pressure volume loop will help us make the selection. It forms the basis of understanding why we choose a particular device for MCS. The area under PV loop here in green corresponds to ventricle work, which directly corresponds to oxygen demand. So the device which reduces PV loop to the maximum best unloads the ventricle. And IBP works on the basis of counter pulsations and reduce relative myocardial oxygen demand. But having said that, diastolic augmentation alone does not equal increased cardiac output, and recent trials fail to show the clinical benefit. It is also important to note that counter pulsation require native LV pulsation as well, and therefore has its own limitations. The more dysfunctional ventricles, the less functional an IBP becomes. In the PV loop diagram, the area remains the same as the afterload reduction is offset by the increased stroke volume, and the ventricle is not sufficiently unloaded. The axial flow Impella devices unload the ventricle better than an IBP. Axial flow pump have drastic effect on PV loops. As you can see hereby, they provide good unloading of the ventricle. But axial pumps have inherent disadvantages. They are very sensitive to afterload, and their high RPM causes more hemolysis, and seen in blue this graph, increased level of plasma-free hemoglobin in the blood compared to ECMO. Also, in cardiogenic shock, we can never forget that about RV support. Only LV support isn't enough. People have stated using bipella, that is Impella CP for LV and Impella RP for RV. As you can see, VA ECMO is the only device on both groups and provide biventricular support. We all know Impella has certain contraindications like mural thrombus in LV or RV, mechanical aortic valve, HOCM, aortic valve stenosis or calcifications, moderate to severe AI, severe PVD, significant RV failure, combined cardiorespiratory failure, and there are certain mechanical complications of MI as well as cardiac tamponade. Now let us consider the ECMO. There are 5 cardinal considerations for initiation and management of ECMO. 1. Patient selections. B. Cannulation strategy. C. LV venting strategy. Distal limb perfusion strategy, or exit strategy, that is bridge to recovery or bridge to destination therapy. As we see with the red arrow, with higher flows on peripheral VA ECMO, without an adequate venting strategy, the shapes of PV loop changes. What happens is LV afterload increases and LVEDV and LVEDP both increases, and that is detrimental for a myocardium which we want to rest. To simplify things, the blue pressure volume loop is of a relative normal heart, and the green PV loop is that of a heart in cardiogenic shock. So what happens after applications of VA ECMO without venting? The afterload and LVEDP and LVEDV increases as seen in PV loop. But we see that as soon as we introduce LV venting to this scenario, the blue PV loop is representing an ideally decompressed ventricle. As we see, there are several direct and indirect options to vent the heart. We can do a small mini thoracotomy and directly vent LV or use a transaortic catheter. So each LV unloading strategy has its own advantages and disadvantages. We'll not discuss in the details right now. So one thing to note from this article by Nex et al., which compared Impella and ECMO in a porcine model of acute myocardial infarction, that ECMO has denoted by the red line results in much lower heart rate compared to Impella, and as we all know, lesser rate translate to lesser myocardial oxygen demand. Also, we have added advantages to assist CABG in non-PCI amenable lesions, and this article by Hamiko et al. Confirms the mortality benefit of ECMO in such situation. So in that study, whenever the patient becomes hemodynamically unstable or lactate increase above 4 millimole per liter, introduction of an ECMO perioperatively improved the outcome drastically. So it is imperative that we take prophylactic steps to prevent lower limb or limb ischemia. Look at this patient. He has a peripheral ECMO in one limb, and in other limb there is Impella and PA catheter introduction. So a 6 French or 8 French sheath in both limbs to provide integrated flow which will prevent distal limb ischemia. So our colleagues in Italy have written an elegant review article which suggests that ECPella, that is ECMO plus Impella, provides the best unloading strategy for a ventricle in cardiogenic shock. Finally, I would like to bring your attention to another excellent article by Kapoor and Esposito, and they recommend a primary unloading strategy when the patient is in cardiogenic shock, followed by reperfusion. Why? They stressed on the aspect of time. Time is money, as we all know. But more importantly for us, time is myocardium. And primary unloading stops irreversible myocardial injury and leads to better myocardial protection and recovery. They have also given an algorithm to guide us based on the measurements with help of a PA catheter, and let's find out where our patient is. With cardiogenic shock refractory to 1 inotrope with a cardiac index less than 2.2, surely with hypoxia and primary VT, he is an ideal candidate for ECMO and LV venting, and which would be one of the ideal options in these patients to achieve our goals of systemic perfusion, ventricular unloading, and coronary perfusion. So thank you.
Chairpersons, if we can have discussion. I think Dr. Chirag Doshi is here. I don't know whether he can unmute himself. Dr. Doshi, can you unmute yourself? We can have then discussion on that as well. I think my question to all of you, Bhupesh Bhai, Dr. Aditya, and Dr. Chirag, if you can hear you, would this COVID scenario change the dynamics of using therapy amongst the three? Case mentioned that the patient had probably RAT positive, or would having a COVID make it tilt towards ECMO?
And I mean, in the first phase, it was different. In the last phase, it was different. I think now we have already courage to enter in the Cath lab. And I think IBP is such a thing which is available everywhere. And Dr. Aditya has very nicely presented on Impella. But I think if you ask cardiologists, 50-60%, they have tendency towards IBP. If you ask cardiac surgeon, they will think about this Impella and ECMO because that is there because large bore this insertion which is required. I think Aditya.
Yeah, I mean, I think the only situation where I would think of ECMO as first line is if this patient is in refractory respiratory failure, if we are having difficulty oxygenating the patient because of COVID pneumonia, in addition to cardiogenic shock, then I would think of VA ECMO. But if it is purely for hemodynamic support, I think, I mean, I would say that, Impella as first line, I mean, we do it in the Cath lab. It's very quick to insert. So I think we can get away without ECMO.
So hemodynamic shock and the biochemical shock. So if patient is going for the biochemical shock, then of course we can go for a very escalation therapy. But when there is only hemodynamics are concerned, we need to prevent them to go into the cardiogenic shock loop, which Dr. Aditya has shown and Dr. Chirag has also shown. I think this is biochemical shock we need to prevent by all means.
Chairpersons, moderators, any other question?
I think all hemodynamic parameter has shown that Impella is slightly better than IBP. All trials have shown that, but in resource limited nations like ours, IBP will always have a place. We all know Impella is available only at limited centers. So IBP is going to stay in India, and definitely Impella in future would be a better option in such cases.
Yeah, I agree. I mean, I think this is one thing that frequently comes up. So definitely the upfront cost of Impella is more, but I think, again, native heart recovery is a big deal, especially for younger patients, for all patients, but definitely so for younger patients. If you're able to prevent their myocardium from scarring, able to recover their LV function, prevent them from going into end-stage heart failure, I think down the road, a lot of cost is recovered from that. Just managing a patient with heart failure. I mean, of course, if they need a VAD or a transplant, that we're talking about a lot of money. But even if they survive without the need for a VAD or transplant, but with significant drop in ejection fraction, we're talking about lifelong heart failure medications, possibly ICD, things like that. So, I mean, those things can potentially be prevented with native heart recovery with Impella, even though the upfront cost of the device is more. So that's the argument that I would say.
Excellent discussion between two speakers. I think Dr. Chirag Doshi is not there. Impella is definitely best, but in Indian scenario, there is still no availability of Impella in most of the centers. And if at all it available, then to take the patient in the theater and insert the Impella, and everything takes time. So before that, we can go for the ECMO or we can go for the IABP. ECMO is also some time consuming, definitely. But nowadays, ECMO is easy for us. Most of the centers are having the ECMO available. So we can, whatever the ECMO or the IABP, whatever easiest to insert and earliest to insert is the first choice. And then if Impella is available, then it's a great benefit for the patient, particularly such younger patients. But Impella, still imagination of Impella at a first stage in the Indian scenario in all the centers is difficult. And Aditya sir, I would like to question you, how much time it takes to insert the Impella when patient first come due to Impella device insertion time?
Yeah, that's a great question. And actually, like I mentioned, in National Cardiogenic Shock Initiative, one of the metrics that we had to meet was instead of door to balloon of less than 90 minutes, it was door to unloading of less than 90 minutes. And we actually met that metric in all these patients with cardiogenic shock. So, we have a STEMI activation when the ER calls us. And Dr. Bhupesha actually mentioned the cardiogenic shock team. So we actually have that at Loma Linda. So whenever there's a STEMI and that patient is in cardiogenic shock, there is a shock team activation that goes out to everybody. So the Cath lab staff, when they come in, knowing that this is a patient with STEMI, they know that it's a cardiogenic shock. So they prep the Impella device. And, even though we are predominantly radial operators, but when there's a patient in shock, we always get femoral access for the same reason, because we are already anticipating putting an Impella in. So it's really quick. I mean, as soon as the patient gets to the lab, get the femoral access, do a quick femoral angiogram, go in with a pigtail, get LVEDP and put Impella in. So I would say, again, we have met this metric of door to unloading of less than 90 minutes. But if you're just talking about Impella insertion, I would say within 15 minutes, we can get an Impella in from getting that groin access.
Okay, that's great. And would you go for all blood investigation to take the patient in the cath lab before the procedure?
No, not really. I mean, all the blood is drawn. But usually the results are not back yet by the time we start the case. So we just proceed, we go ahead anyway. The one thing that we have implemented in our center is to run an ABG, because you get a lot of information just by running the ABG. You get lactate and everything. And ABG is usually point of care. So they run it very quickly in the emergency room. So we have some labs available, but not all.
Okay. Thank you so much. Moderator can have any chat box question? I think one chat box question is there. Okay. So if there is no any question, then we can conclude the session.
Yes, thank you. Thank you very much, both the speakers, all the three speakers. Dr. Chirag is being connected, but I think he's having some issue for the discussion, but I could talk to him on phone. Thank you, all the chairpersons, Dr. Jigisha, Dr. Gaurav, Dr. Raj, Dr. Abhimanyu, Dr. Kilol, and Dr. Harsh Gonia. And thank you, Aditya. It was great connecting to you, and we'll be looking forward to have you and host you in next year, maybe, hopefully. Thank you, Bhupesh Bhai, and thank you, Dr. Chirag Doshi. Bye-bye. Take care.
Bye-bye. Bye-bye.
Thank you very much. Thank you.